All right, hello everyone, both here at the Icahn School of Medicine and also online, all 130 virtual participants.
Yes.
So great to be in virtual community with you and to see you, theoretically your faces. I know you're out there. I'm really trusting the magic of the internet right now. I am Bethany. I'm a second year medical student at Mount Sinai, and this event is being hosted by the Human Rights and Social Justice Program here at Mount Sinai. We have a class full of students here from that program, as well as some other medical students and trainees at Sinai. And that is also being funded by Sinai's Office of Diversity and Inclusion and the Intersex Justice Project and Interact Advocates. So thank you all so much. Also like to start this event with a land acknowledgement, which has been written by some of my classmates here at Sinai, and I'd like to share with you all both virtually and here in person. While we recognize that the people are perhaps joining us on this forum from all over, given that we are all students from various New York medical institutions and institutions across the United States of America, we think it's important to acknowledge the land on which we are based. This land where we're speaking from right now is the land of the Wapninger, Munsila, Lenape, Canarsie, and Rockaway peoples. With that recognition comes the unwavering commitment to decolonize and unsettle not only the physical spaces we create and share, but also our hearts, minds, and politics, as well as an unwavering commitment to critically challenge the conditions we have been socialized to accept, and an unwavering commitment to pursue collective liberation. So thank you for reflecting on that land with me, and this message will be echoed throughout this entire talk. And so now I'd like to turn over the mic to our 4 amazing speakers and let them introduce themselves.
Hello, Sinai. Hi, everybody. Awesome to be here. I'm Hans. My pronouns are none of them, so just Hans. It's great, my name. I'm an artist and educator, previously worked as communications director at Interact, where I focused on messaging and legislative strategy around intersex issues, including passing some of the first state-level legislation in California to affirm intersex rights.
Hi, my name is Casey Orozco-Poor. I use they, them pronouns. I am a student researcher at Harvard Medical School. I'm a 4th year intersex ally within medicine who's, been doing some work to challenge the status quo within medicine about the care folks are getting.
Hello, everyone. My name is Bria. Pronouns are they and she. Some of the identities that I hold very close is that I am a Black, queer, masculine presenting, non-binary, and intersex person. I work as the Director of Engagement for Interact Youth. I've been doing intersex advocacy work for about 2 years now and am really grateful to be here with you all. Thank you so much.
I don't know if folks can see me. Maybe should I come a little? Yeah.
The camera's right. It's that one bar.
But
Oh,
just,
those folks.
yeah. Should I sit?
Can you see Saifa when he sits there?
Okay. I'm just going to introduce myself.
Oh, yeah.
What's up, y'all? My name is Saifa. I'm co-founder of the Intersex Justice Project. I'm so glad to be here with y'all. Thank y'all for coming, for the people. Thank y'all for the folks who are online. Just amazing work, amazing advocates, and I'm so glad to be in conversation with y'all.
All right, should we take it away?
Get the one. You want to open?
So this doesn't work. This is a pointer, but you can't. Yes, and then we're gonna have Saifa. Yes, it's arrow. We're gonna have Saifa do a nice little grounding activity for the next 2 minutes.
All right, y'all. We're working out the kinks. So essentially, what I want to do, I think this is the perfect place to do it, because we're in an institution, right? And we're in a medical institution. So for the folks who are tuning in from home, but also for the folks here, I'm an activist. I'm an intersex activist, but I'm also a somatic practitioner. And I do somatic awareness work with individuals as well as with groups, looking at how sensations show up in the body. And so I wanted to, given that we're talking about the body, I think it's only right that we actually engage our own bodies. So this is, a consent practice. People can consent to this or not. But for the people who are, I'm going to ask you to really, you can just get comfortable in your chairs. And kind of like sit with your feet about hip width distance apart. And also for the folks who are joining us at home. And if, I'm going to ask people to get really still. No texting, no distractions, no typing. I'm going to ask people to get really present with what's showing up in your body right now. Sensations, thoughts. So the centering practice, we center for the purpose of getting connected to ourselves, the land, ancestry, as well as legacy. I want to acknowledge that this has been a hard year and a half, almost 2 years for people. There are people who still haven't been able to leave their houses for being chronically ill and just wanting to survive. And I think we've also been disappointed by how our government has shown up or not shown up. This has been hard on a lot of people. So let's just take a moment just to let that register for a minute. So we center in 3 directions. Our length, which we associate with dignity. Our width, which we associate with boundaries and expansiveness. And our depth, which we associate with ancestry and legacy. Let's start with our length. I invite people to really feel the floor underneath you. I also invite people to let go of any tension you may be holding in your jaws. Unlock your arms. Put them on your lap. Connect with the floor. Connect with the earth. Imagine that your body is like a tree and your head is like a canopy. Different people in this room come from different places. And at times we've had our dignity compromised. Maybe in this institution right here. So what does it mean to take up a little bit more space in this length, this long part of your life? How does it feel? Is it something that you welcome? Is it something that makes you very uncomfortable? Get curious. So if people want to know where your center is, it's about 2 inches below your belly button. There's a lot that happens in that place. So from center, I invite people to widen out. Really feel the outer edges of your body. The space between your feet, between your legs, between your hips, between your shoulders, between your ears. Being a human, there are people who have crossed our boundaries. And sometimes we've crossed other people's boundaries. And I think sometimes within these institutions, we're invited to not take up a lot of space, especially if you hold multiple identities. Being a woman, being queer, being disabled, being trans, non-binary, being immigrant, refugee. So I invite people to take up a little bit more space in your body. So from center, I ask people to center in your depth. We exist on this plane, this big spiritual plane. We've lost people. We've lost beings. Those represent our ancestors. So if you can, really feel into someone who you love, who is no longer on this plane with you. Really feel them at your back. And as we move toward our legacy, with a heart that never stops beating, lungs that expand and contracts, taking in air, a stomach and a gut that churns information and food for the nourishment of our bodies, let us all be reminded that we all will die. We're all going to die. And so in knowing that, what do you want your legacy to be? How do you want people to remember you? What do you want people to know? So I invite everyone to take a collective breath into your center. And before we start this panel, I invite everyone who's joining us virtually and here in the audience, turn to someone next to you and just share, how you doing?
Doing good.
That should help with feedback sound.
Wait. And people who are joining us virtually, you can sound off in the chat. Just share how you're doing, how you're arriving. All right, thank y'all for your time, and let's start.
All right, we got feet on the ground, yeah? Welcome, everybody.
Thank you.
Always good to give a heads up. So this is a heavy talk. We talk about things like abuse, assault, torture, genital mutilation, and unwanted procedures at the hands of medical institutions. So take care. If anything feels like it's too much to bear right now, you'll understand. Step away, do what you gotta do. But so glad to be here, and so glad to be here with all of you, in particular, as medical students, health workers, people who are going to have a great amount of power in people's lives. And from what I've heard from med students, there isn't often a lot of mention of intersex topics in curriculum. Has that been true in y'all's experience? Getting some nods. And if anybody online, has anything that's come up in their curriculum, I'd love to hear about it. But glad to be here today because often, if there is any mention, it's kept in a very narrow clinical, medical, scientific lens. And we're here today to expand that context because there are so many lenses through which to understand intersex issues and broadly what that represents for so many other systemic issues. Because there are so many ways to have a body, right? If you look at literally every other human trait, pigmentation, hair, skin, height, whatever, incredible variety. So why would genitalia, sex traits, any of that be any different? Whether you're somebody who was born with a vulva or a penis or whatever configuration, I'm pretty sure that everyone in this room and everyone online, everywhere has experienced some sort of self-consciousness around sex traits, gender, just being made to feel a certain way about your body. And, if anyone wants to share some of those ways, open to it in the chat. It's a very common experience, and I think that intersex people maybe experience a much more, well, I don't want to judge, but perhaps a more extreme heightened version of that through the fact that intersex people, these differences are considered significant enough by the medical institution to be monitored, to be changed, etc. And we've got a definition here. I don't know if Casey, if you had anything to add on the definition at this moment in particular. I'll keep this one up in case folks want it for reference. But it's important to understand when we talk about sex, there's so many layers to that. There's a scholar named Anne Foster Sterling who describes it as a symphony. And sometimes those parts play together and sometimes they don't. There's 7 different aspects of sex. And intersex people usually have significant differences in at least one of them. So sex is comprised of many things. Most people, well, I always think it's important with med folks, especially to offer some language and to offer some frameworks of understanding bodily difference in ways that are inclusive to intersex people, ways that are inclusive to transgender people. So when I talk about traits, we use the words male and female to talk about what is really two buckets, two paths of development, right? So most people fit into these and go kind of straight down the line, right? Intersex people are very creative. There are so many ways that we can do it different. And some of them are more significant than others, but sometimes you mix and match. Sometimes you skip a step. Sometimes you come up with something completely unexpected. And I love to think about it that way. I love to think about it in that way because the world has been often so cruel to us. So I'll note too that often in medicine, intersex variations are referred to by their medical diagnoses names. And there's a place for that. I think sometimes there is, a use for that in determining people's individual needs. But I try to talk a little bit more generally in terms of traits because there's so many ways that things can combine. So it could be chromosomal differences because chromosomes are just a blueprint. They're not a destiny. It could be in gonadal tissue on the inside where nobody can see it. Maybe you have ovaries, testes, a mix of those tissues, or maybe nothing, maybe undeveloped or street gonads that just never happened. Or maybe it's in your hormones, right? Everyone has a different balance, whether you produce more estrogen or more testosterone, what your environment is like, and your body's response to that, because not everybody is the same. And sorry, I should have given a heads up. There is a general drawing because this is medical education, and I think that it's important to know and at least have a reference of what things can look like, because it's never both. I think that's a very unuseful myth. It's really a series of spectrums. So all of these parts are homologous tissues. Everyone has erectile tissue, whether that's larger and the urethra comes through it and that's a penis, or whether that's smaller and it's more towards the clitoris side of the spectrum. Everyone has something that is, scrotum, labia, and you can see that's also a spectrum. And also the degree to which that opens, and there's internal, reproductive anatomy and an opening, is also a spectrum. So intersex people might fall, as you can see, somewhere in between on this line, including the development of the urethra, because that's a part of sex development in which the urethra either comes through for the penis or separates for the clitoris, and that's sort of a remnant of being a difference in that process. So I'm sure that everybody knows, or maybe has some idea of the issues and the reasons why we're here, being unwanted surgeries, right? That's kind of the name of the game. And so I try to give a little bit of a brief overview of how we got here. And of course, the answer, as always, the Scooby-Doo monster is the usual, patriarchy, racism, homophobia, the usual systemic culprits. But intersex people have always been disruptive. We've always caused quite a panic, being very threatening to a lot of these systems. So scholars have documented that, in England, in early Europe, records were centered around marriages. And marriages were validated by penetrative sex, by being able to have children. And so intersex people are incredibly threatening to that, or they don't always fit into it. And furthermore, sex variation threatened a lot of other social constructs, like racial hierarchy. So there was a great panic that if there wasn't truly a binary in sex, or if some people could be born appearing female and then later change, what did that mean for other social hierarchies, like race? It really caused quite a panic, and still does. Including, of course, double standards, right? Racial stereotypes of, people with intersex variations that are not white, and, all intersex people, by and large, by medicine being considered monstrosity, and medicine taking it upon itself to fix those people, to make them fit into the systems that exist. So medicine became a tool to enforce those fears and to protect the institution of heterosexual marriage. Again, as scholars have documented, some of those first surgeries, even before anesthesia, were to validate marriage and penetrative sex. So things like increasing the depth of a vagina in order to be able to validate a marriage for penetrative sex. And before anesthesia, that sounds pretty brutal to me. So I think that gives some indication of just how intense this can be. You know, an academic that I'm a big fan of calls it securing a cisgender future, securing a heterosexual and cisgender future to make sure that bodies fit into those systemic models. And throughout time, there's always been a false quest to find that one thing, that one true marker of sex that will tell doctors if they should modify this person to put them in the female bucket or the male bucket. And what that marker is has shifted very much over time. So originally, I want to say 1800s, that was gonads. Whether you had ovarian or testicular tissue was your true sex. And if somehow that was discovered, intersex people could be victim to things like forced transition by the state. So having to live in a different role because of doctors finding the facts of your body. We moved into genitals because, of course, kind of difficult to see someone's gonads, right? But again, there's holes in that. And today I would argue very much that we're in the era of chromosomes. Since about the 1950s, that has often been interpreted as the true marker or the clue that doctors can look for in order to determine if they should do surgeries on an infant. But again, you know, I'm confident that everyone here and in the chat probably has a good idea about their own gender identity, but how many of us know what our chromosomes are? Anybody? I don't know. I got one hand maybe, but you know, chromosomes are not destiny, and they're really not that useful of information because as we saw, there's a lot of different ways that can develop, and that doesn't necessarily correlate at all to gender identity, as we will learn with folks. So, you know, this happens at fine institutions like Mount Sinai, right? So the language that Mount Sinai uses to talk about intersex people is rife with concepts of problem and condition and using teams of doctors to determine chromosomal gender, which I don't think is a phrase that has very much meaning. And, you know, historically and even today, it's been based on what's easier for the doctors, you know? There are social and cultural determinants of, you know, if it's more popular to try to put people more in the female category or more in the male category. And often that has, you know, been influenced by surgical technique and what's easier. Still mentioned on Mount Sinai, which I thought was something. And so, of course, the controversy is what's significant enough to be intersex? Who's in, who's out, you know? We talk about a number 1.7 to 2%, but breaking down what that number is, it's from a literature review on several specific medical diagnoses by an academic, Anne Fausto Sterling, made a list of a bunch of different intersex diagnoses, you know, kind of did the math to aggregate and see how common those different ones were. And in my book, this matters, and it doesn't. Statistics can be useful in knowing that you're not alone in something that is, you know, common enough to be able to find other people. And simultaneously, if we think of this as a violation of rights of ethics, does the number of people matter? Should it matter how many people, you know, have this particular cause or that particular cause when we're trying to address the ethics and individual autonomy behind practices? So there's been quite a squabble over the years over medical diagnoses, these labels of terms that describe specific patterns of traits. And there's a place for that. But we see the medical labels and the squabble over what medical labels deserve protections from surgery and which ones don't, which usually correlate with how common they are numerically. But as activists, we kind of reject that. I reject that medicine has the power to define intersex because it's really more of a community term that we're pushing to be based and understand as being based around shared social experiences. Bodily difference, shame, unwanted surgeries, those common experiences, rather than being limited to one medical cause. And I would say that it's even values-based, the idea of intersex and the people who adapt that word, because not everyone adapts the word who's diagnosed with a difference in sex development. There's some people who say, no, that's not me, I don't want that. But to me, and in my activism, I see it as something that's aligning around these values of dignity, autonomy, justice, self-determination, crossover with a lot of different movements. And this is a photo of the first public intersex protest in '96 in Boston. The group called themselves Hermaphrodites with Attitude, after what was written in a lot of our medical records, mine and probably a lot of folks, being a hermaphrodite or a pseudo-hermaphrodite, and taking that medicalized slur back and finally demanding dignity and showing up as who they were. And I know I've heard from some older intersex activists that they thought that in this first time, showing up and sharing their stories, that'll be it. They'll change. The medical institution will change. That'll be enough to change their practice. And here we are, 30 years later. It's a slow burn. I think it's burning. And so we see, we're fighting for depathologization. And other groups, if we're looking at kind of an alphabet identity model, have won that, because if someone here were to say, being gay or preferring, same-sex relationships, whatever you call it, is a mental disorder, you kind of look at that person funny at this point, right? So homosexuality or, LGBT have sort of achieved being recognized as just human behavior, being depathologized. And I think we're getting there with trans issues as well. Sex variation, not so much, certainly not in the eyes of the World Health Organization so far, who released information or changed their information about how they consider that for trans issues. And so here we are trying to tell our stories and make change with medical folks based on those patterns of shared experiences, of being made to feel like there's something wrong with you. But I don't think there really is. So I know Bria is going to talk about their personal experience.
I am. Thank you so much, Hans.
Yes,
Beautiful
Hans.
intro.
Yes, Hans.
Hello. To reintroduce myself, my name is Bria Brown King. Pronouns are they and she, and it really is such an honor to be here with you all in the room and everyone joining from home. And just to be here and share this space with intersex activists that I've looked up to for so long, for so many years. I've been doing this work again for about 2-3 years. And every time I give a talk, I think it's important to acknowledge the folks who have paved the way, movement leaders who have paved the way and made it possible for me to be here with you all today. So shout out to Saifa, who I actually first saw in a BuzzFeed video titled What It Means to Be Intersex. That video changed my life. I saw it about 3 years ago. And shout out to Hans, who was actually my very first intersex mentor when I became Interacts Communications Director back in 2019, and really helped me find my voice as an advocate. And of course to Casey, who isn't intersex, but I think Casey shows us just how important and how powerful our allies can be when they join us in, this fight for intersex justice. So thank you all. I am just so grateful for you. And so my intersex variation is congenital adrenal hyperplasia, or what we commonly refer to as CAH. And CAH is one of the more common intersex variations. And so I'm actually going to offer my definition of what this means for me, and then I'll hand it over to Casey as the med student, who will follow up with a more technical definition of the term for the medical folks joining us. But first, I'll say that it took me so many years to wrap my mind around what it meant to have CAH, what this term meant. Oftentimes, medical language just isn't accessible to the average layperson like myself. And, being able to explain things in a way that makes sense is so important. And it's especially important for non-medical folks like myself. So I was born with CAH. I was born with XX chromosomes. I was also born with ovaries, as you can see here on the screen. But my body doesn't produce enough cortisol and for the non-medical folks, cortisol is a stress hormone that our bodies needs to function properly. It regulates things like our blood sugar and helps our bodies respond to stress. And so to compensate for that lack of cortisol production, my body actually produces higher levels of testosterone, which is a category of the androgens. And testosterone produces what we typically refer to as secondary male characteristics. So things like facial, body hair, muscle mass, bone.
Okay, I'm also going to this over. Here's the thing.
Are people still at home?
Hmm?
Are people still? Oh,
Yeah,
okay.
yeah, they're still here. They're just the
Okay.
slides on.
Oh, it's so funny.
People are saying, yeah.
Yeah, they're like, we're still here. We're still listening.
But I love how it comes to right here. It's like a mirror image.
Okay, perfect. Thank you so much. Again, so oftentimes I hear things like, oh, my child is not intersex because my child has XX chromosomes and can technically conceive, right? I actually had a parent tell me that I was asking young girls to give up their quote unquote womanhood by supporting and advocating for bills to end non-consensual surgeries performed on children. Because in this society, there are still people who believe that womanhood is tied to a person's ability to engage in penetrative sex and have babies, right? We'll talk a little bit more about womanhood later on, but first I'll let Casey hop in and give us a more in-depth overview of CAH.
Great, yeah, this will be, thank you so much. Yeah. I am going to go back a little bit to just speak out loud the definition of intersex. So intersex people are born with or develop variations in one or more of their 7 characteristics of sex. And these 7 characteristics, like Hans went over again, chromosomes, genitalia, gonads, internal sex organs, hormone production, hormone response, and secondary sex characteristics. That's a very important framework. Okay, so using this framework to talk about congenital adrenal hyperplasia, you can see, like Bria was saying, due to an enzyme deficiency in 21 hydroxylase, which is the most common CAH variation, individuals are not able to go along the cortisol pathway, and they're unable to make cortisol at a level that is healthy. And we'll go into the spectrum of that, but there are folks that, can make sufficient amounts of cortisol and folks that make a lot less cortisol. And so the endocrine treatment would be titrated to, how much cortisol an individual has. Although that is something that doctors should fix, we need cortisol. The result of having high cortisol is, the result of having low cortisol results in an increased amount of androgens, and in utero, these androgens like testosterone result in genitalia becoming on the spectrum between like a penis and a vagina. And so what people call this in medical terms is clitoromegaly. And the genitalia of individuals with CAH are not like a pathology. They have nothing wrong with them. They are fully functioning. Their nerves are working well. Nothing wrong with them. And so what we're saying is, although someone might have an endocrinological condition that does need treatment, it does not mean that their genitalia are abnormal or that they need surgery. It's also important to note that people with CAH actually comprise 95% of what is considered XXDSD, so that'll pop up in the literature. And there's a lot of efforts with physicians to exclude people with CAH from the intersex umbrella so they aren't legislated. Here is the enzyme pathway. You can see here that because there isn't the 21 OH hydroxylase, that the steroid amount goes down and the androgen amount goes up. And here is like a spectrum of CAH. So there's what's called salt wasting, not salt wasting, and non-classical type. Salt wasting is the most impacted by cortisol, and so these individuals need cortisol from birth, and actually many babies used to pass away before they were given sufficient treatment, so it is a medical emergency. But it goes all the way to non-classical type, where people actually don't have a cortisol issue, and the only issue they really have is this quote-unquote issue of masculinization, which we will talk about. All right. You want to
Thank you so much, Casey. So now I'm going to share a little bit about my own personal story. So sometimes people don't learn that they're intersex until they start puberty, and which is typically when secondary sex characteristics, like I mentioned earlier, like facial and body hair, muscle mass, fat distribution, etc., start to come about. And so this was sort of the case for me. While I was born with genital differences that were apparent when I was born, I actually didn't know that I was intersex until I was about 12 to 13. And I saw my friends going through puberty in a way that was very different than what I was experiencing. I had a puberty that was both feminizing and masculinizing. So I was growing a beard and body hair at the same time that I was growing breasts and menstruating. I will also note that I honestly didn't really realize that I had intersex traits until other kids and other people around me started to point those differences out. In my mind, right, I just look like myself. And something that's also common for folks with my specific variation is that we experience precocious puberty. And so for the non-medical folks, this just means that I went through puberty at a very early age. And so not only was my body changing, it was also changing far earlier than the rest of my peers. But unfortunately, I didn't have access to the knowledge and the information that I do now to explain to people why my body was changing. And, people ask questions, kids ask questions, and so do other adults, teachers. And I didn't have access to that information. And people were curious. They wanted to know why my body was changing, and I also wanted to know. So fast forward to 2018, I had just finished college, and I was kind of trying to figure out, what we do when we finish college. I was trying to figure my life out, right? I was trying to figure out what I wanted my future to look like. And so then I got a little bit more curious about my body. And so I did what most of us do when we want answers, right? We go to Dr. Google. And so I went straight down the Google rabbit hole and just trying to find out more information, trying to find any answers I could. And that's when I found the BuzzFeed video that Saifa was in. And it featured live intersex people in the flesh, interacting with each other, and they were embracing their intersex bodies. And that was such a beautiful thing for me to witness, because I had never experienced anything like that. And I always get so emotional when I think back on that time, because it was so special for me. So the following year, on Intersex Awareness Day 2019, that's when I came out as intersex for the first time publicly in an article that I published in Them magazine titled "What Dating as an Intersex Person Taught Me About Self-Acceptance." And so another shout out to Hans, who was and still is such a wonderful mentor and helped me get that piece out. I always say that finding the intersex community, finding Interact, changed my life. Finding that BuzzFeed video changed my entire trajectory. I say that I do this work not because I want fame or clout. I do this work because I want to inspire young intersex people, right? I want to inspire young Black intersex people, young Black intersex youth, and let them know that it's okay to live their truth, and that it's okay for us to exist beyond the confines of sex and gender, this binary that society tries to fit us into. And I also share my story as a testament to the resilience of the intersex community. It's not easy for me to stand here. It's not easy for me to be so vulnerable and to share my story with the world, to people, to strangers, to people I don't know, right? A story that I couldn't even share with myself for so many years. I still remember the very first time I actually sat down and wrote up my story for the very first time. It was for a written testimony that I submitted for a resolution that Interact was actually working on in California. I remember that my heart was racing, my hands were sweaty and shaky, much like they are now. And, I knew that I was doing it because I knew that if my story could at least help one person, if my story could somehow prevent the trauma that I had to experience, then I knew that it was worth it. Oh, and these are my cute baby pictures, if I didn't mention that earlier. And so we are all probably familiar with the anti-trans legislation and anti-trans bathroom bills that say things like trans people have to use the bathroom according to the sex that they were assigned at birth, right? A bill like this also affects intersex people because there are intersex women, for example, who have XY chromosomes. Which bathroom are they supposed to use? I mean, I have XX chromosomes, but when people look at me, they see a man. Which restroom do I use? Even today, there was a whole thing before we got started about me needing to find a restroom that was gender neutral that I could use before the talk. So, and also to that note, school is already hard enough, right? School is already so much to deal with. And schools are also really obsessed with separating things by gender, in addition to restrooms, right? Even uniforms are gendered. And so I don't think that people realize, though, what a privilege it is to not have to think about which bathroom you're going to use, or if you're even going to be allowed to use the bathroom to begin with, especially when you're a young person and you have to sit in a classroom all day. So thankfully, the Supreme Court ruled in favor to protect LGBTQ plus people from workplace discrimination under the Civil Rights Act. This is a picture from that event 2 years ago, October 8th. This was my very first public event. I was also very nervous and shaky, like I am today, but I got to speak about why intersex people deserve to be protected from workplace discrimination. So, we also know that it's illegal in some states to offer trans affirming care to trans kids. Because when it comes to gender affirming care for trans folks, lawmakers like to say things like, oh, well, children just need to wait until they're mature enough to have gender affirming surgery or to start HRT because this can have psychological impacts, right? Which I think is a very interesting justification, considering medical professionals have been performing these same surgeries on intersex children for decades without our consent, right? Forcing intersex people into surgeries, forcing intersex people into surgeries that will make them rely on HRT for the rest of their lives, because when you remove a child's gonads, their body can't naturally produce the hormones that it would have naturally produced, and then it puts them at severe risk for things like osteopenia, where their bones become very weak. And it's just every time I think about these horrific surgeries that are still happening, it makes my blood boil. I'm really passionate about this work that I do. When it comes to things like anti-trans sports bills, we see that there is this obsession with women and women's bodies and their testosterone levels, right? Talk about the patriarchal policing of women's bodies, right? And while these bills are they are designed to target trans and intersex women, cisgender women are also affected as well, because it means that anybody's gender can be called into question, quite frankly, if you don't fit society's definition of womanhood, and if you don't fit society's definition of what a woman's body is supposed to look like. Which leads us to the final part of my talk where we talk about why the idea of womanhood is so bogus and is a social construct and also inherently anti-Black. And so, again, thinking back about that parent who told me that I was asking young girls to give up their womanhood, right, by supporting legislation, you know, that aims to end non-consensual surgery on intersex children. I know that the parent was saying this because in society's mind, there's this idea that there is a right way to have a body, right? There's a right way to look like a woman, and womanhood is defined by a woman's ability to have penetrative sex with a man and have babies again. There's also this idea that women are supposed to look a certain way. And to be honest, when I hear things like this, and when I hear parents talk about not wanting to have an intersex child, I hear them saying that they don't want to have a child that looks like me. And to add a layer of intersectionality to this idea of womanhood, we also know that there has been a history of Black women's bodies being perceived as too masculine, right? And even more so when you're a Black woman who has power and influence, right? We've heard this about women like Serena Williams, women like Michelle Obama, women like Meg Thee Stallion. This discourse is rooted in both anti-transness and anti-Blackness, and society's extremely jaded perception of what it means to look like and be a woman, especially if you're Black, right? This idea that women can't be too tall or too muscular. Women can't be any of those things because those traits are inherently associated with men and masculinity. So, you know, we can kind of start to see how those traits are, we can kind of start to see how all of these issues kind of intersect. In 2009, Olympic athlete Caster Semenya, her right to privacy was completely violated when her test results were leaked to the press. And that's when the rumors started to spread and about the test being done to measure her levels of testosterone, right? And I actually believe this happened just hours before the race was about to start, and then she was deemed ineligible to compete, even though the official results weren't yet released. The same sort of thing happened to Dudi Chand, who is an Indian sprinter that was also banned from competing due to having high levels of testosterone. This year alone, we see this trend, with this past Olympics, we've seen this trend continuing with two other sprinters from Namibia. Okay, thank you. Women being deemed ineligible to compete due to having naturally high levels of testosterone. So talk about privacy violations. Imagine having your medical information plastered in the headlines for the entire world to see, right? This idea that intersex women are born with gold medals in their hands because of their testosterone levels is just not true. And also, it's clearly discriminatory because it only applies to women's sports. We're not having this conversation about men, right? And as someone who was born intersex and with high levels of testosterone, I assure you that I am not inherently athletic despite what my body might look like. I'll finish by saying that I think it's time for us to reimagine the way we think about sex and gender and reimagine, this whole binary and start to imagine a future where everyone has the right to self-determination. Thank you.
All right, so we're going to talk a little bit about the data. Thank you so much, Bria. That perspective is so important. Thank you. We're going to talk a little bit about how doctors warp the data to justify continuing to do these surgeries. So despite many people with CAH, coming out, identifying as intersex, this study, and dates are really important. So this study came out in 2019. It was written by Dr. Dix Papas, who we're going to talk about a lot. He said, regarding people with CAH, that they shouldn't be included in the definition of intersex because 95% of people with 4/6 CAH who are raised as female do not experience gender dysphoria. That number is from a study that was done in 2005. And the way that they did this study is that they determined gender dysphoria was if a psychiatrist diagnosed an individual with gender dysphoria from 1950 to 2000. This clinical tool has only been validated for binary trans people and has not been validated and does not capture the gender diversity within intersex populations. And so if you see this study that they just keep citing over decades, that was done 1950 onwards, I think it's worth noting, just for the study, I think it's worth noting the cultural pressures to not disclose gender incongruence to a psychiatrist or your parents from the 1950s to the 2000s, so that's a factor. But even when people did report that they did have dissatisfaction with the female sex, that they did have more quote unquote masculine behaviors, this actually didn't even get counted into the definition of gender dysphoria. And so you see here, gender dysphoria, no, 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 gender dysphoria, no, no, no. But then you see these asterisks. These females identified themselves as females, but on measurements, they indicated feeling less typically female. Another asterisk. They showed less female typical identification. Another asterisk. These girls did not feel gender dysphoric, but they felt less content with being female, or more often expressed the wish to have been born male. But all of those people are not counted in this definition of gender dysphoria. And this is how doctors are able to manipulate data in order to erase the gender diversity within intersex populations, to continue performing genital surgeries to quote unquote normalize people, which is an extremely violent framework. I discussed this. So now I'm going to go through 2 decades of data since this article that does demonstrate that there is gender dysphoria. Not gender dysphoria necessarily, but gender diversity within the CAH population. Here are some quick stats. 37% of individuals with CAH question their female gender identity. Women with CAH reported significantly less satisfaction with the female sex assignment, and 31% indicated having wished to be the other sex during the past 12 months. 31%. There's like this clear female to male gender dysphoria. That's the measure that they were using previously. But obviously, this is like a very high number of like 10% of individuals who actually go through the process of like transitioning from like quote unquote female to male. Here's another rate of gender change that is 7%. 10% in this study did not have a female gender identity. And it's interesting how they word it too, right? And so these studies, this is done in 2009. These studies are saying that individuals are at risk of gender identity disorder or gender dysphoria. 15% of females are at risk. And so when you position it like this, they justify giving, these surgeries to avoid the risk of gender identity disorder, which is transphobic. I mean, that's just transphobia. And this study actually shows that when people are assigned male at birth and who have CAH with a high degree of masculinization at birth, actually do really well with that gender category. And throughout the data, it actually shows that the sex assigned at birth and gender assigned at birth is actually like the biggest indicator, and not necessarily like these diagnoses that people put. Another 1/3 of people with CAH had male gender identity scores. 25% engaged in 4 out of the 5 behaviors that like constitutes like quote unquote cross-sex identification. And again, more male-like behavior in childhood, greater rate of homosexuality, greater difficulty with vaginal penetration. It's like what Hans was saying. It's like all of these like risk factors among people with CAH are just like risk factors for being trans and gay. And so it's viewed in the literature as like a negative outcome. CAH patients saw themselves as significantly more masculine than their physicians. And I wanted to just talk a little bit about what's on the Icahn website. So this is like a grand rounds that was done at Icahn, and it shows here that the goal of giving like cortisol is also to minimize quote unquote androgen excess. And they even say in order to control the androgen excess to avoid masculinized features, often requires extra or odd dosing. And that they actually did studies that found when people weren't given this excessive amount of cortisol, they actually had a higher chance of identifying as masculine. And I think it's really important to recognize that we're not going to talk about the endocrine part too much, but the purpose of like the endocrine treatment of people with congenital adrenal hyperplasia is so fixated on reducing hirsutism, which is just facial hair growth. And they literally say no side effects of oral contraceptive pills. In this article that was written in 2013, there are a lot of side effects of oral contraceptives that like aren't even viewed as relevant for individuals with CAH because it's just so important to reduce their masculinizing features. And this actually results in individuals with CAH getting way too many cortisol, getting way too much steroids. So many people with 21 hydroxylase deficiency are actually overtreated because of this fear that they're not going to look like the ideal women that like Bria was talking about, which is an incredibly harmful approach to take with patients. This results in suppressed androgens, striae, which are like purple marks on the skin that come out when you have too much cortisol. And it also decreases the bone density in your body for children, which is like extremely bad. And so there's a higher rate of fractures, and these studies haven't necessarily been done looking at like the fracture rate of people with CAH, but if they have decreased like bone mineral density, then they're going to have issues with their bones. Okay, so now we're going to pivot to talking about some of Hans and Saifa's personal experiences.
Right. You want to go home?
Thanks, Casey. Well, I had a slide for you first. But
Okay. I can go first.
You want to go first?
Okay.
Yes.
How's everyone doing? Everyone's okay. People are like, yay. Yeah, I just want to express my gratitude for all of y'all. I don't know why I feel a little choked up. I think part of it is, what I like to say is that these practices exist within rape culture, right? Where the perpetrators of these actions, these behaviors are often held unaccountable. And so I feel like, as someone who has been doing this work since 2004 and seeing the previous generation of activists, right? It was in Hans's presentation about hermaphrodites with attitude, and I can share a little bit of that history. I think for me, like recognizing the trauma, right? The people who were part of the Intersex Society of North America, people who were with hermaphrodites with attitude, people who were traumatized and who actually spoke out. And they did it so that I could be an activist. They passed the torch to me and to others. And it's like, for me, as I'm moving toward I'm 42, right? I'm about to be 43. It's just like, I see this next generation of activists, and it's like my duty and my job to pass the torch once again. And we've been saying the same thing for almost 30 years. Since 1996, even before then, right? It's been like over 30 years. Intersex ISNA was founded in 1993. And it makes me really angry, makes me really sad that we've been saying, I've never been part of a movement where the narratives have been consistent, right? And we've been saying that we have been harmed by these practices, but yet these practices continue. And that's a problem. I was looking on your slides, Casey, and I saw two names, Dr. Akira Morishima, and who's passed. He was a pediatric endocrinologist at Columbia Presbyterian Hospital, and Dr. Anka Earhart, who is still with Columbia Presbyterian Hospital. She co-wrote the book with Dr. John Money, Man, Woman, Boy, Girl. Both of those were my doctors. And it burns me up that Dr. Earhart everyone knows money, but Dr. Earhart has been flying below the radar, still doing these CAH trials, right? Still causing harm, but she's so insulated that it's so hard to get to her, right? And so when I confronted the man who castrated me, I actually wanted Earhart. I actually wanted to look her in her face, because I remember sort of being a young person. I had the surgery in 1992. And she actually was, her and another clinician named Dr. Fairbanks, they were my therapists. And I distinctly remember Dr. Earhart asked, she was just like, because I came out at 14, and she was like, does the estrogen make you feel less gay? I never forgot that. And I remember after I read the book As Nature Made Him by John Colapinto, I saw her name in there, and this was in 2000, maybe 2005. I sent her an email, and I was like, you did not win. You did not win, And I feel like for me, what motivated me around intersex activism is just like what I experienced, the violation that happened to my body without thorough informed consent shouldn't happen to anyone, right? And of course, doctors would say, oh, well, we told Mrs. Wall, that, all the things, right? All the things that doctors like to say, but they didn't tell, well, first of all, let me back up. My body was changing. My body was masculinizing because I was born with a variation that is in my family, that's genetic, which is androgen insensitivity syndrome. I had partial androgen insensitivity syndrome. I was assigned female at birth, but my body was changing, right? It was masculinizing, but I felt okay with the changes. I didn't understand them, but I was okay with them. And Dr. Morishima told my mom is that these gonads, they have to be removed because they're cancerous. And so my mom, who has cancer in her family, right? She heard the word cancer and she's like, oh, we have to do the surgery. And so I was castrated and I was put on feminizing hormones, which feminized my face and body. And those changes I still live with, even as I transition, right? And even taking testosterone doesn't do the same thing for me that my own gonads did, that my own testes, let's be honest, that my own testes did. And so that's why, this is like, this is why I fight. This is why we all fight. And I want to end off on one thing. The slide that I saw earlier, Hermaphrodites for Attitude. There's this queer academic, his name is David Rubin. And he said that Hermaphrodites for Attitude, because I always thought the name was strange. It was actually taken from the rap group back in the day, NWA, Niggas with Attitude. And they were like, okay, well, we're going to be hermaphrodites with attitude. Just shows you the lack of, racial awareness that exists back in the day. And for me, I co-founded the Intersex Justice Project with Lionel Stephanie Long and Pigeon Baconis because we wanted to actually bring back direct action and medical accountability from a grassroots perspective by intersex people of color to advance change. And it's actually speaking to the work that was done in 1996 during that first action. And so I will hand it to Hans. But thank you all for listening.
Saifa. And actually here was our lovely Saifa slide.
Oh, nice.
Beautiful work, Saifa and Mecca Basant. So I don't often talk about my personal story because I found that it's made activism more sustainable for me not to. But I'm going to a little bit today. because I think it's important, and I think that everybody here has the potential to affect a lot of change. So I was able to have a normal, weird childhood. And, as a person who found out they were intersex as a teenager, I sometimes felt that I wasn't enough, or that the positioning of what it felt like both doctors and both activists who had absorbed a lot of that rhetoric, I felt in a way that since I hadn't had, such severe experiences or felt like I hadn't had surgeries at birth, that I wasn't, enough to belong to this category. Things changed, but I found things out when I was a teenager and never went through puberty. And everyone else around me seemed to care a lot about that. And so I ended up finding out as a teenager, the work of fellow folks who were in that position, like Bria, really has made a huge difference for me. But when I was going through that process as a teenager, I didn't have the language for it at the time, but it was, I think, internally apparent to me, and is apparent to me now, how important it was to everyone around me that I fit into a certain idea of white womanhood that cared about fertility, that was docile, that was not outspoken about anything that was going on, and that, of course, deferred to medical expertise that would make me receptive and that would make me pleasurable to men. And so the surgeries and the hormones that I went through in high school were largely to that effect. And some of the art that I've made is on this topic. So doctors were very concerned about what I would be like to men. And one of them told me, let's get you on estrogen so you can develop for your future husband. And that, as we saw in the history, remains the framing that through everything I went through as a 15-year-old, doctors were incredibly concerned about fertility being an outcome for me. So, oh, maybe there's a chance you can still have kids, maybe you can still be pleasurable to a husband, etc. But that was absolutely the framing that I got. And, here's surgeries, here's hormones, here's your medical records, inscribing that you are a pseudo-hermaphrodite, for the record, and, be on your merry way. Not a lot of follow-up. So I count myself very fortunate in the way that I was a nerd as a child, and so that made me good at Google at a time that was earlier. And so I was able to get a lot more information. Sources like ISNA, I think, folks like Saifa may have been putting out some stuff at the time, but I was able to find more resource on this that was not medical, because of course, the medical framing to me was, we need to change you so that you can be fit within this certain idea of white femininity. And the word intersex, of course, never came up. And so I was able to meet with folks in Chicago. I found, just stroke of luck that year, that there were people there for an annual conference. And these are folks like Georgianne Davis, Linnell Stephanie Long, who Saifa mentioned, and Pigeon Pagonis, who are IJP co-founders, folks who I met in some of those earlier intersex support group spaces, who really made me feel able to talk about this. I count myself as very lucky that I sort of grew up in a way that almost felt like I had a culture around being intersex, that I had exposure to so many people at such a formative age. And the intersex support spaces that I was in at that time were wonderful. They were pivotal sources of support. And I could also see how in some ways they were not accessible to me and probably to many people. The focus was largely around assimilation, around, I'm just a normal woman and I would like to have children. I would like to adopt. I would like to get married. And it was often a space that was by and for, one type of intersex narrative, someone who's, a white, well-resourced woman who's interested in saying, no, I'm normal, let me blend into this. And of course, that was a very palatable narrative as well for medical partnerships, for a lot of those kind of types of rhetoric being absorbed. And so pivotal to have those access, to have those support spaces ended up not being the most accessible to me, and I can assume probably not very accessible for a lot of people. Things have changed a lot. And I think that's amazing, because support has been so pivotal. To be here with everybody today is quite something. And I find a lot of solace through activism. So for me, that domain is media and communications and making some of the resources that maybe I wish I would have had. So, you know, folks have participated here in some of those projects. And, you know, I've written about it, but as an intersex person, I'm not a big fan of the framework of coming out. Kind of rubs me the wrong way, especially because I guess just fundamentally it puts the onus on that individual who's navigating so much to have to fight and carve out space. And also because as an intersex person, I don't think a lot of us get that space. That so often your first exposure is so violent and so medicalized, and you're so exposed to doctors and family members who want you to be and look a certain way with those most intimate changes. And it's a lot. So advocacy gives me solace. And I guess that's what I'll say. Just happy to be here today and really optimistic, really hopeful that the next generation of health workers will take these stories to heart. And yeah, I hope you will.
We're probably gonna go over, yeah, all right. No break. But I will circle back to the slide and leave it at the end. But if you are a medical student or provider interested in future action, please contact Saifa. Saifa has done such incredible work in New York City with Columbia med students organizing around this. They have a petition. And so, yeah, so we gave you all the slide deck. If you need the slide deck, maybe Bethany, can you drop that one more time so they can get to that slide if they need it? All right, so it's really important to recognize that these surgeries, although they're normalized within medicine and medical school, have been determined to be medically sanctioned violence and torture by the United Nations and the Human Rights Watch. The UN Committee Against Torture in Germany, the UN Committee on the Rights of the Child, the UN Committee on the Rights of Persons with Disability, and the UN Nations Committee on the Elimination of Discrimination Against Women across many different countries have all determined that this is torture. So I think it's really important to talk about anatomy, right? Like, I don't know, at Harvard Med, we did not learn about like the penis at all. Like you were there just like kind of, you know, it's there and it's bigger than the vagina. It's bigger than the clitoris and the vagina is also there. And that's like kind of it. Like we don't really go into like a lot of the neurological wiring of the genital system or even like the spectrum of different types of genitalia. You're just kind of taught this is one pathway, this is the other pathway, you're either male or female, and if you're not, you get surgery and hormones to fix them. So here's the anatomy of the penis. And so I'm gonna be talking a lot about the dorsal nerve. Notice how the dorsal nerve wraps around and is like on the dorsal aspect of the penis and the clitoris. And then here's the cavernous nerve. And so the cavernous nerve actually goes into the erectile tissue itself, and I will talk about that. But it's very important to recognize that there are two major nerves that innervate the penis and the clitoris. The cavernous is the autonomic. So that helps you with engorgement. That helps you with penetrative sex if you have a penis and desire that. And then you also have the dorsal nerve, which is thought to be more of a sensory nerve. And so these are the surgical treatments, surgical torture that is happening at Weill Cornell Medicine. And it's very important to recognize how language impacts how people understand their children's bodies. So they call them developmental anomalies. They say it's more natural to have a more normal appearing vagina, and you don't want to be on the severe end of the virilized spectrum. That is how they justify these surgeries to families. I'm going to argue that there is absolutely nothing normal about amputating someone's sex organ. No. Bethany. Oh, it clicked. All right. This is fun. Great. And so just to recognize leaders in the field, these are people that are determining what the appropriate size of a clitoris is. And so this is written in 2007, very updated research. So if the clitoroplasty surgery is undertaken, it is done so with the intent of providing an appearance that aims to closely resemble the typical female phenotype. And the most common reason of having these surgeries is congenital adrenal hyperplasia, which is why we're talking about this today. I want to give a content warning to folks in the audience. The studies that I'm going to cite are violent studies. They contain themes of medical violence and very stigmatizing language. I will be reading direct quotes from the studies to illustrate what they think, but those are not words that you should use. And we've already talked about affirming frameworks, and we'll also give you more resources. So this is not like to set an example. This is to say that this is wrong. So in 2001, this group of researchers, Creighton and Minto, have done a lot of great work in this regard, basically came to the conclusion that these surgeries should not happen because they damage sensitivity, and that there's no objective data that they actually reserve any sensitivity. So that was done in 2001. Since 2001, there has been this increased attention to the nervous system, to the genital nervous system. And so now individuals are saying, well, those studies done before 2001, they didn't count our new surgeries. Now we have nerve-sparing surgeries. And so the treatment of the enlarged clitoris, they talk about how to, kind of keep track of how the nervous system is doing. And the two things that they use to keep track of how the nervous system is doing is intraoperative imaging of the nerves and electromyographic responses. So I'm going to talk first about the electromyographic responses. So this study in 2017, which is new research, cites something in 1995 that says EMG results are not significantly compromised. So then it shows this, allow for preservation of nerve conduction in the dorsal neurovascular bundle. Here is a description for EMG. Basically, EMG looks at the contraction of the muscle, and it actually looks at these. So it looks at the contraction of the muscle, which is modulated by large nerve fibers. That's a very important point. However, it's shown that although there is the study in 2005, which did show that there was positive EMG activity. So when you stimulated when you stimulated the area, like a muscle would contract, it doesn't guarantee normal sexual function. And there's actually an individual who responded to this article that was written and said, I had a complete clitorectomy. So that's a complete dissection of the clitoris, absolutely no sexual function. And they still showed positive EMG activity because the EMG activity is not looking at sensory function. It is looking at these large fiber, actually, it's not it. So basically, there are different axon sizes, right? And different axon sizes give different types of information to the brain. And the most abundant axon in the genitalia is what's called free nerve endings. And those are actually very, very small nerves, and they're present in a ratio of 10:1. So they're the most abundant sensory cell in the genitalia. And so when you're looking at EMGs, they're actually only assessing what's happening here with these larger nerve fibers. See these extrafusal, intrafusal muscle fibers, Golgi tendon organ, muscle spindles. These are all larger fibers. And so the reason that they're not able to retain sensory function, even if they have a positive EMG result, is because they're not looking at the right types of nerves. So these are actually the types of nerves that really matter. And it's these really small ones that especially matter for sexual function. And in response to the individual who reached out saying that, I don't have any sexual function, I don't have any sexual sensation, but the EMG still resulted positive, they said in our article, while this proves nerve conduction and sensation are retained, it does not guarantee normal sexual function. And so just the way they word things is very misleading. The second mechanism of, quote unquote, assuring the nervous system is intact after these very violent surgeries is intraoperative imaging of the nerves. So there was a study done in 2007 by Dr. Dix Papas, who is a world-renowned surgeon. People come all over internationally in order to get their child's genitalia operated on by this individual. He carried out a study that was supposed to prove that the dorsal nerve was retained in his surgeries. May ensure adequate sexual function, that wording is important, promotes a consistent gender identity, and provides a normal clitoral aesthetic. So those were his goals. Here is a diagram of his surgeries, and it's important to recognize, so in his surgeries, he leaves the neurovascular bundle, which is this, and he cuts out all of this erectile tissue. He cuts out all of the corpora cavernosa, so all of this is removed. He used histological stains to talk about how there was a scarcity of large dorsal nerves in the tissue that he removed. But it's really important to recognize that although his study said that the large dorsal nerve was retained, he removed a large amount of nerves from these individuals. 10.7 plus or minus 2.1 nerves per specimen. And the nerve sizes were very large. It was 59.5 plus or minus 35.7 micrometers, which you can, I won't get into that. But he's saying that he didn't actually remove the dorsal nerve. These are just the branches of the dorsal nerve. And if there's anything you take away from today's lecture at a neurological level, please, for the love of God, register that like the branches of nerves matter, and they're actually the things that are bringing and sending away information. He used this thing like OCT to like demonstrate. So basically so he did this study. He removed the majority of the clitoris from these children. And then he took that tissue sample from 3 individuals, and he said that, before the surgery, you could visualize the dorsal nerves from 600 to 800 micrometers. And after the surgery, no nerves were visualized. So, there's no nerves that we removed, even though he didn't like really specify that those are any nerves below 600 micrometers, which is a very large like nerve. And so these surgeons do not have the neurobiological training to be making the claims that they are making. These surgeries are not nerve sparing. They are clitoral amputations, which destroy the nervous system of the genitalia for individuals. This is an example, branches matter in neurology. Please, please, please know this. It's also important to recognize that the images that he's showing in his studies aren't even anatomically accurate. And there is a recent study that shows that branches of the dorsal nerve penetrate into the corpora cavernosa, and that nerves, the cavernous nerve and the dorsal nerve actually communicate, and that makes a lot of sense, right? You want your sensory and your autonomic system to be communicating. But when someone removes the entire corpora cavernosa, they remove the entire nervous system, the entire cavernous nerve, engorgement potential, etc. And so I argue that his diagram should really look like this, right? That there are branches of the dorsal nerve going into the corpora cavernosa that are getting cut out, and this entire system of autonomic, spongy, erectile tissue is completely removed. So when the dorsal nerve branches are cut, it prevents the dorsal nerve from receiving full signals. When these nerve endings try to regrow, they risk forming painful neuromas because their tissue target is removed. And so especially in young people who are able to regenerate nerves, that's not even necessarily a good thing because they regenerate chaotically and cause a lot of pain for individuals. It also severs the somatic autonomic nervous system interaction, which can be very harmful to sexual function. And so I think this is just like an updated diagram to demonstrate that although he says it's nerve sparing, he is taking out all of this tissue. That is not nerve sparing. And so they say that it's not a clitoral amputation because they don't remove the entire clitoris with the clitoral hood. But these surgeries are not safe for the nervous system. It's really important to recognize that like the amount of space in your brain that the genitalia represents is enlarged, and it's actually magnified in the brainstem. And so we have no idea what these surgeries are doing upstream to people's brains, how they're able to conceptualize intimacy, how they're able to conceptualize sex. It has upstream effects that we don't even know how to measure. And they're saying that these things are nerve sparing. I think it's important to demonstrate like this like argument like that happened at Harvard for this talk that I boosted that ended up being like this ethical debate, which is completely inappropriate, and I have to write an email about it. But basically, there was like this debate about like who gets to decide these surgeries, and then it's like this individual and other people kept saying like, when the evidence is limited, equivocal, or contested, then it's like kind of a negotiation, and that there aren't like really clear guidelines. And this search for equivocal data in sex functioning has resulted in deeply immoral medical sexual violence. Vix Papas in 2007 released an article, this is the article, in which he demonstrated to the world that he conducted sex testing on the genitalia of 5 to 7-year-old children. What he did was he put a vibrator on their clitoris that he had surgically shortened, and then they put a vibrator on their thigh. And then he asked them to rate, is it more or less than your thigh? And so because of these specialized nerve endings that he didn't remove from the neurovascular bundle of the dorsal nerve, there was increased sensation compared to the thigh. But that does not tell you that you still have like intact sexual functioning, and it's also sexual assault and abuse. We do not do this to young children. This is unacceptable. This is not in any way acceptable medical practice. And no one in the medical community said anything. No one in pediatric urology said anything. No one in urology said anything. No one in endocrinology said anything about these studies. And it was only until Alice Dreger and Ellen Fetter did a report in 2010 that this even got any attention because the medical community did not think that this was an aberration from their practice. And it's important to recognize he didn't even get IRB approval for this because he said this was part of his surgical practice. And so he did not have to go through an IRB approval process in order to do this. Just in a brief amount of time, there are a lot of complications for these surgeries. If you're interested at home, you can read these. I think the most important study, and even this is actually a great study. So even surgeons themselves, like in 2013, they polled all of these pediatric urologists at this conference. They're self-reporting 26% poor results. Like these pediatric urologists are coming in and they're like, we're really just botching this a fourth of the time. They're saying that about their own surgeries. And in this cohort, which I believe Dr. Dick's Papa's surgeries are within this cohort that's being assessed, there's a complication rate of 27%. A fourth of these surgeries are not going well. And when the surgeries go well, they are still neurologically devastating. This is a significant study. This study was done in 2008. And so they actually looked at 9 individuals who got these nerve-sparing surgeries. No one had intact, oh, I don't even have the stat. Oh yes, okay, this is it. No one had intact feeling to cold, temperature, and vibration. No one. None of the individuals with CAH who got these surgeries had intact sensation, including the people who got nerve-sparing surgeries. These surgeries don't work. They do not spare nerve function, and they always damage nerves. It's actually quite devastating to the nervous system. So there have been advancements. Boston Children's Hospital will no longer be doing clitoroplasties or vaginoplasties. Lurie Children's Hospital ended intersex surgeries largely due to the actions of Saifa and the Intersex Justice Project. In Interact, it really demonstrates that although we sit in these ivory towers, it's really direct action that is really pushing things. And we should have a high regard for direct action. Direct action is regarded in medicine as some sort of trifling little annoying voice outside that we should be ignoring. Direct action is where our hearts and soul should be in medicine. We need to listen to our patients who are saying they are being harmed. The heart and soul of medicine needs to be in our patients' hands. This was a fantastic educational bill that was passed in New York recently. This is a resolution that makes October 26th Intersex Awareness Day in the state of New York. And this was a huge big deal. New York City Health and Hospitals actually instituted a policy to defer all medically unnecessary surgeries on intersex children. But that doesn't include Columbia. That doesn't include Cornell. That doesn't include Icahn. None of these private institutions. And so now me and Hans are going to talk about some affirming models in care. These are just some words from intersex folks that I find really grounding. Stop doing infant genital surgeries. Hear our pain, give us hope, treat us with respect, understand God made us this way and we are good. I think I'll let people read this at home, but this is anything you'd like to say to other people with congenital adrenal hyperplasia. Lots of folks with CAH who are doing educational outreach and letting people know that they're not abnormal, they are not severely virilized, they are whole individuals with their own self-determined lives. This is a really important point, but we didn't talk about parents that much. This German interdisciplinary consensus paper determined that parents are only allowed to decide on behalf of their children in the case of vital harm. And I think this is just such a lovely, please watch this after you're done, because Ori can explain intersex conditions in a minute. So next time a professor tries to say you don't have time for it, be like, this 10-year-old child described intersex issues in a minute and a half. So it really is possible to incorporate into medical education. I think it's just really important to also mention that if someone has a clitoris that doesn't look like what we expect a typical male, a female clitoris to look like, it does not mean that it is wrong. Having a big clitoris is a pretty big boon for sex. If you really want someone to have intact sexual sensation and have a fulfilling sex life, it would be to leave their sex organs alone because they are healthy. And I think we need to normalize looking at different types of vulvas, looking at different types of clitorises, looking at different types of penis, all of this spectrum of genitalia, because it is okay to look and be different. And as medical providers, we cannot be operating to change difference. We need to be fixing pathology. So that would be too little cortisol and someone is not able to thrive. That is not genital surgery. This is an awesome resource from Interact. These are just like ways to, refer to things in intersex inclusive language, for example, as opposed to born with ambiguous gender. Like the word ambiguous is like not something that we want to be using. It's kind of thinking about genitalia outside of the typical male-female binary is like a way to say that. Here is an example of a talk given at Fenway, just to think about using affirming non-gendered language. Offering that to all your patients actually would be really helpful. Non-binary like health approaches would also be very effective for intersex people, asking people for their pronouns, avoiding assumptions, and describing anatomy and related terms with gender inclusive language. And then did you want to talk about this, Hans?
Yeah, I guess I can briefly.
Okay.
I wasn't personally involved in this one that far, but this is a guide that Interact wrote with Lambda Legal. Literally spelled it out, everything you got to do, how to provide affirming healthcare to intersex patients. Freely available PDF on their website with Interact resources. If you go to the next slide, Casey, there's another one too that came out more recently that was specifically focused on affirming primary care. So, the documents are there. Folks have really laid out the steps and would love to, hear about some adaptations of these documents. And of course, Interact has a pretty thorough list of PDFs and guides, resources in that department. This was a brochure series from a while ago that youth wrote, talking to doctors about what they wish they could do in terms of affirming care. And something that I always plug too, so this collage was from an article that we put together about MDs who are outstanding in their intersex advocacy work. And something that folks can always do is to ask those hospitals, ask about their curricula. As we showed a couple of slides from how Sinai was talking about these issues, I always try to bring it to be a little bit local to the institution. Students have, I'm not a med student, but I know folks have advocated for curriculum change. What else we got, Casey?
And now, thank you so much for listening to all of that. We're running a little over, but I do want to give, if people could stay online, if people could stay in this room, I do want to give Saifa some time to wrap up this whole talk. And I really appreciate it if you'll stay.
I just want to give a shout to my fabulous panelists. Y'all are so great. Y'all are so great. Yeah. I just want to just wrap it up. Thank y'all for the folks who decided to stay online as well as here.
Can you please talk about how some doctors don't want patients to consider themselves intersex? I have Turner syndrome, and I've told by a geneticist that I don't have to be intersex.
Right.
Well, why would doctors want there to be less intersex people?
Right.
Is a great question. I mean, I think there's some incentives there for sure. But I think classically the positioning was that only the people with the most freakish defects all the way over here with the most noticeable genital differences fit the bill, are unambiguously intersex, and we can call them that. And anything else is not. And that definition, which I think often a lot of advocates even ended up absorbing, kind of parts of that train of logic, kind of ends in more surgeries in my book also, because if someone's not intersex, as we're seeing with all of these CAH debates, it's kind of a weird, like they're not intersex, they're girls, which justifies the surgery. So I think that positioning really serves like kind of what Casey was talking about with benefiting the medical institution and perhaps some of those individual providers themselves.
And
Sorry, I'll also just add that we are not forcing anyone with an intersex variation to identify as intersex, right? We're not the people in business to police how people identify, but I will say that as someone who has CAH and is a part of CAH spaces where I hear a lot of this rhetoric, we fight for those people too. We include them in our work, even if they don't identify as intersex, because they still deserve to be protected from these horrific surgeries. And, there is a lot of fear associated with like having an intersex body. And fear oftentimes is the decision-making factor. Unfortunately, parents are afraid of raising an intersex child. And Honestly, that's what it really comes down to. Fear is the decision maker, unfortunately.
And what I want to add is that there's a bias that exists in medicine, right? Prior to 2006, they would refer to intersex variations as hermaphrodite, male pseudohermaphrodite, female pseudohermaphrodite until 2006, right? And so essentially, providers then felt very uncomfortable using the term intersex, now will not use the term intersex. More providers are increasingly using the term intersex, but there was a study that was conducted that came out of Europe. Basically, providers do not use the term intersex with, parents or patients, right? They prefer to use terms like disorders of sexual development. They may use differences of sexual development, but they do not use intersex. They do not use intersex variations. And I think that's a way of continuing to medicalize and pathologize people with intersex variations. Because when people actually find each other, when people actually use such terms like intersex, then they're actually able to tap into these stories, right? They're able to see Hans's story. They're able to see Bria's story, right? And so I think it's purposeful that providers do not use the term intersex because they associate it with being activist, they associate it with being radical or disruptive. So they prefer to continue using DSD. In Europe, they may say variations of sex characteristics, which is, a lot of people who don't identify as intersex may say, I have a variation of sex characteristics. But essentially, doctors then and now do not feel comfortable using the term intersex with their patients.
Right. And I will, just to add to that, I didn't find the intersex community until I was 25 because whenever I, would do any searches, I was looking for information about my specific variation, support for people who have CAH, and I didn't find any. It wasn't until that BuzzFeed video, and I'm so glad that I did. I know that doctors see us as the emotional activists, but again, I know that there are people who have CAH that don't identify as intersex, but I am so glad that I do. I have, the support, the community that I've gained from being a part of the intersex community has really changed my life. And so,
Can I add one more point? Clearly, we have a lot to say on this one. That point is transphobia. I think it's also that this picture has been painted that there's those freakish intersex activists over here, who of course we don't want more of, but I think there's become this binary of intersex being contrary to man or woman, as if you can't be both things, as if intersex isn't just an adjective that describes, a state of being or community. And so I think that position, which seems very rooted in transphobia, is a factor too.
Yeah, it's too,
and I just want to point out that in CAH spaces, there is a lot of fear associated with the term intersex. Every time the conversation about intersex and surgeries comes up, it gets hostile. I will say that. And oftentimes I get a lot of personal messages from people who are afraid to speak publicly about being against surgery, for example, because they will be attacked by parents who say that, no, my daughter is a real girl because she has XX chromosomes. And it's just so absurd. I want y'all to know that this stuff happens. And I give myself about 2 times a year to engage with people in CAH spaces because the emotional toll that it takes on me is so much as one of the only intersex people in that space. But, again, I do this work for, the few people who might reach out to me and say, thank you for sharing your story. Thank you for being an advocate and speaking out against these surgeries. And, I want to offer that space to people who don't want to conform and don't want to, who are ready to open their eyes and realize just how absurd all of these points that they're making actually are.
All right, I really want to answer 2 questions in the chat. Other arguments made by pediatric urologists in favor of early surgery is that prepubertal children tend to bleed less and heal better from surgery. So that's actually not true. I've been talking to a surgeon and another neurologist about how these surgeries, which affect the nervous system, are actually quite bad to do in childhood. And there's this statistic that, like, challenge this data, challenge the hell out of this data, because if you dig deeper, it doesn't hold up because they're bad. It is bad to do these surgeries. Nothing will ever prove that they're okay. And so this was biological reasons for operating early include maternal estrogen effect on infant tissue, satisfactory results, and reduced risk of urinary tract infection. Literally in all of the things that they cite, like I was not able to find a single mention of estrogens in all of their citations. And all of those citations that carried forward in the literature, carried forward, they're doing bad science because they get paid for it. They get paid to do bad science. And so I think it's so important to recognize that, like, this is like really like avant-garde and contemporary approaches to like biology, and it's not anti-biology. It's actually more scientifically valid than what people are doing now, because what people are doing now is derived from social understandings of what like a male and female should be like, but the science, because it's reality, shows something else. So just the data is so sloppy. And so if anyone ever tells you like, oh, it's like safer to do like surgeries in infancy, and you're like, okay, why? And they're like, oh, maternal estrogens, be like, literally, where did you find that study? Because I have not been able to find it. And the only study that I've been able to find had like absolutely nothing to do with intersex surgeries. It was talking about like like milk hormones and like looking at like the vaginal wall of like infants, and the maternal estrogens actually go away in a month. And none of these surgeries are being done under a month. They're usually done like after 6 months. So that's not even like a real data point, and it's just been carried in the literature, but it's a lie. And then this argument that like people don't remember the trauma of surgery. There are a lot of intersex people with horrific memories from when they were like below 4 years old. And there was actually an incident at Boston Children's Hospital that my friend told me about, of like a 4-year-old being like strapped onto the bed for their like 3rd surgery for like hypospadia. We're not going to get into hypospadia right now. That's a whole thing. But it does still have a complication rate of 27%. Screaming, kicking and screaming, needing to be held down to the stretcher with a gas mask put on them in order for them to have surgery. How traumatizing. Right. How traumatizing. Like that is a 4-year-old child. And like they're definitely going to remember that. So I don't think that's a valid argument either. And then regarding the question about the cryptochordae, yeah, so the gonads cancer question has been really sloppily done in the literature, but basically like the concern around the cancer risk for gonads was like completely disproportionately misrepresented. And then they ended up doing studies that found that it was no higher a cancer risk than people who just had internal testes. And you can just release like an internal testes. It's like a temperature thing. But now the standard of care for AIS has moved more towards retaining the gonads until after puberty, and then like doing regular checks on like if they're developing cancer. If you have streak gonads, that's different. Like if you have like undifferentiated tissue, the cancer rates can differ, but just having gonads inside of your body, if like you have if like you're female presenting, like doesn't inherently increase cancer risk. There has to be something like about the cells themselves that are like under differentiated, which is what like predisposes to cancer. And having a fully differentiated, completely healthy gonad inside your abdominal cavity isn't going to significantly increase cancer risk. But that fear has been used to like castrate people over decades. And it's only until recently that they're like, actually the science doesn't show this. So that's inevitably going to happen with like all of these things. I just want to emphasize like the sloppy science behind a lot of these claims because they're not even true.
Could we check in on time?
Yeah.
How are folks doing?
Sorry, we really kept you here. Okay.
Yeah, close it out.
All right. There's one more question regarding progress in intersex variations in standardized medical education. Like, it's been extremely difficult. I've gotten in a lot of trouble for it. You all will be incurring risk by participating in this. And I think that like there has been great like progress, but it is definitely like a very controversial field. But I'm happy to talk with anyone offline about medical education stuff. And I will leave you with this slide. If you want to work with us, this is the CAH Mega Deck. If you want to work with us, if you want to participate in this work, it's so helpful to have like collaborators, and like the more people that are involved, the more safe it is for people like me, like because it's really easy to silo students, but if you all go in a group, you will not be siloed. And so I think there's a lot of strength in numbers, and the more people you can get to sign on to things, the more it kind of ripples out and affects positive change. So
that's real talk. And the thing is, you know, if people can collaborate across medical schools, right? The thing is the strength in numbers. So they're like, you know, yeah, increasingly, there are more medical students who are actually committed to like doing med school curriculum change, you know, or people like, we're gonna have an event for Intersex Awareness Day. We're gonna bring in speakers for Intersex Awareness Day. I think there are things that y'all can do, right? Like you can actually start organizing like your genetics professors, your anatomy professors, really start getting in their ear and being like, how do we actually have intersex affirming curriculum that actually reflects, you know, the human body? Because I spoke to someone recently who said that they change the medical curriculum every 20 years. That's
I didn't hear, I don't know about.
well, basically, at least at UCLA, they change the medical curriculum every 20 years. So yeah, I mean, there are things that y'all can do, concrete steps that y'all can take toward actually like affecting change here at Mount Sinai.
Okay, we'll stop.